Thank you very much for the opportunity to speak here. My name is Ed Connor. I'll start off first with a few disclosures. I think the first and most obvious is that I'm an employee of Ultragenyx. I've worked there for 2 months and have been very excited to be leading the 001 program for GNE Myopathy. My second disclosure is that I'm not a neuromuscular specialist. I'm certainly not a glycobiologist. I'm an allergist by training and have spent the bulk of my career treating and studying new therapies for patients with very, very severe asthma. I recently was fortunate to work on Pompe disease, which is another progressive myopathy, and I'll draw on some of my experiences as I talk to you today. And my last disclosure is not so much a disclosure, more an apology for what I think is probably the most potentially, right here, the most potentially boring title of the talks that we have today. I looked across the list and realized that the title of our talk didn't quite have the creativity that most of these other have, so I apologize for that. This is a talk actually that was given by Dr. Heather Lau at NYU at last year's World Muscle Society. The original intent was to just give you the talk wholesale. I looked at the slides, and as I'm relatively new to the company, I thought I'd give my own impressions on how we've arrived to where we are today, and maybe weave in some of my experience with regards to how we think about conducting the best clinical trials for patients with this disease. So with that being said, I will go over a few background slides. I'll go through them relatively quickly. We have experts here, of course, both the patients and the excellent researchers from the NIH. Most of the data that I'll show has been generated by them, so they're clearly much more capable than I in terms of going over the background of the disease. But with that being said, what is GNE myopathy, also known as HIBM? It is a severe progressive myopathy due to a deficiency in an enzyme in the sialic acid biosynthesis pathway. This enzyme is called GNE-MNK, and patients typically present around the ages of 18 to 13 years old, usually with weakness in their muscles of their legs, have a foot drop, but as Jennifer mentioned, every patient is a unique individual and everyone presents differently. I've shown some pictures here. This is atrophy, both in the legs and in the arms. You can see in the skeletal muscle tissue, you have rim vacuoles, and another name for it in the past was DMRV for the rim vacuoles. And then lastly, the MRIs. And I wanted to point out a few things here. For those of you who are not familiar with patient MRIs, I wanted to orient you a little bit. So this would be a patient lying flat on the MRI scanner with their legs out towards you. So this here would be the left leg, and this would be the right leg. And what you can see is the quadriceps muscle, which this looks like muscle tissue, is very much intact. And another name for this disease was quadriceps sparing myopathy. But what you can see here in the hamstrings is replacement of that muscle tissue with fat and fibrosis. And when we talk about substrate replacement therapy, that has important implications because substrate therapy, if it works, will work on healthy, intact muscle, but is very unlikely to work on tissue that's been replaced by fat and fibrosis. And we talked about what are some of the treatment options, how are we moving those forward. The focus of my talk will be on substrate replacement therapy, but I want to talk, at least briefly touch on some other potential strategies. As I mentioned, the goal of substrate replacement therapy, because there's a defect in the sialic acid production pathway, is to replace with sialic acid. That can be done either using sialic acid-rich compounds like IVIG or precursors such as Manac or other derivatives. Gene therapy, which I won't be talking about today, would be to use a virus to insert a functional copy of the gene into the patient's genome and have them produce their own normal levels of sialic acid. And then stem cell therapy, and these would be where you would have stem cells with a functional copy or a functional enzyme, I should say, that you then make differentiate into muscle tissue and the associating neurovasculature. That's more obviously aspirational at this point. The last thing I'll say, and you touched on it, Jennifer, and we were very fortunate to have Tara come up and speak to the company very recently. And as she was talking, she mentioned that she has a very consistent exercise regimen. And that a light went off in my head because my most recent experience with Pompe disease, where patients lack the GAA enzyme, there is a GAA enzyme available, it's called myozyme, but it doesn't get into the muscle tissue very well. So what some researchers have done is actually have their patients exercise while they're getting the substrate replacement therapy. And they've shown some success in actually getting that in. So I think it's important to look at this disease holistically and think about, with any potential therapies that we have, we need to think about the best ways of delivering them. So this is schematically what I discussed before with regards to the biosynthetic pathway for sialic acid. You could start with MANAC or theoretically anything below that to provide the sialic acid that is low in these patients. In our case, we've chosen an extended release formulation for sialic acid to maintain it at a stable concentration because sialic acid, the half-life is generally quite short. And we felt it was important to have consistent levels around because this will support muscle growth and repair at night. And then lastly, and Dr. Blickton is here and will be presenting later, this is data generated by her in her lab. They have a very excellent mouse model of HIBM and show that if you give either MANAC or NUAC, which is sialic acid or sialolactose, you can have these mice, which would otherwise have highly abnormal tissue, have normal muscle tissue, and you can show that the run distance normalizes to what you would expect to see in a wild-type mouse. So all of this evidence that substrate replacement therapy may play a role in helping with this disease. Again, to walk back a little bit, I want you to think of that MRI where you have the healthy muscle in the quadriceps and thinking about what can be done for the muscle that's been replaced by the fat and fibrosis tissue. So just be keeping that in mind as well. So I will go into our phase 2 data, but I also wanted to talk a little bit about the drug development process. As you mentioned, we're all, or all the patients really want something available as soon as possible, but it is quite a long process. And I just wanted to give an example of that to walk through with regards to the preclinical or toxicology programs. So there were 22 toxicology studies that were out in the literature in Japan, but we felt, and also the health authorities appropriately felt, that GLP or good laboratory practice studies needed to be performed so that so there would be some safety data prior to giving this to human patients. And so we did safety pharmacology studies, in vitro studies, and or what's known as chronic toxicology studies. Generally, it's 2 species. In our case, it was the rat and the dog. And we did not see any significant toxicity, even at the highest dose, which is 2,000 milligrams per kilogram. That term down here, the NOEL limit, is the no observed adverse event limit. And 2,000 milligrams per kilogram in a dog or a rat roughly translates to a 30 to 60-fold increase above what we are giving in our clinical studies. So we then did a phase 1 study. I won't show that, but I will say that we did see the levels of sialic acid come up and stay maintained with the extended release formulation. I'm happy, I have that data with me. I'm happy to share it with whomever, whenever. You can just come find me at any time. But that leads us then to our phase 2 study. And I want to slow down a little bit here to really walk you through the design. So it is a 48-week randomized, double-blind, placebo-controlled study, but I see it very much as being in 2 parts. The first part is this initial 24 weeks, where you have the 47 patients who are randomized into one of 3 treatment groups: 6 grams, 3 grams, or placebo. So that first 24 weeks I see as really being the placebo control comparison for the study. The next 24 weeks, you take the placebo patients, and they were then in turn randomized to either go to 3 grams or go to 6 grams. So when we analyze this data, when we look at the data and try and understand what this shows with regards to how Sialic may or may not work in GNE myopathy, we look at what's called the combo 3 group, which is patients who either started on 3 or went from placebo to 3, compared to the combo 6 group, which again is either patients who started on 6 and have kept taking it the whole time, and also includes patients who started on placebo and then went to 6. We didn't specify any primary endpoint. We had key endpoints. Paramount, of course, is safety, and then also looking at serum sialic acid levels. But one of the initial detours I want to take is thinking about how do we measure muscle strength. This is a disease of progressive myopathy or progressive muscle weakness. So how do we best measure changes in muscle strength? What we did was look at what's called the upper extremity composite. So that would be how strong your grip is, how strong your shoulder abductors are, how strong your elbow flexors and your elbow extensors. In the lower extremities, what you'll notice is absent is looking at knee extension. So knee extension would be that kicking motion right there. The reason that's not included is because that largely is due to your quadriceps muscle. And as I showed previously, that quadriceps muscle is largely spared. So when you think about a composite endpoint, you want to have roughly equal contribution. So we study that independently of including it in the lower extremity composite. We also did a 6-minute walk test, a sit-to-stand test, and then I'll talk about the GNEM FOS or FAS in just a little bit. So again, how do we measure muscle strength? So if you've ever had a neurologic exam or you've ever given a neurologic exam, typically what you do is you have the patients move their muscle against gravity and you test it to see how strong it is. And you might say it's a 1 or a 2 on a scale. The issue with that is that there is known to be a lot of inter-rater variability. And what I mean by that is that one physician's 2 might be another physician's 1 and vice versa. So thinking about how are more objective ways to measure muscle strength, dynamometry is a device where it's essentially a pressure plate, and then you're seeing how much weight the patient is able to displace. So some examples here, you might have it in your grip. How much can you squeeze? You might have it next to your knee and you're bringing your leg in. How much weight can you displace? So it is a more objective way of being able to demonstrate muscle strength. And this is the data in the upper extremity composite from our phase 2 study. So I want to point your attention to the left side first. This is the placebo-controlled 24-week portion. So the green is the 6 gram, the red is the 3 gram, and the blue is the placebo. So what you can see is in the 6 gram, there might be a slight gain or stabilization, whereas in the placebo or in 3 gram group, they look to be about the same and had a decline. So you do see a difference there that I think is more easily seen potentially when you look out at the 48-week data on the right and you see the combined 6 group, and I just remind you to think about what that is, compared to the combined 3 gram group. So what you're seeing here is stabilization of muscle strength for 48 weeks in the 6-gram group compared to the 3-gram group where you have progressive decline. And we also looked at a subset where patients were able to walk more than 200 meters. The thought being that these patients are earlier in the course of their disease and might have more muscle that would respond to substrate therapy. And in this group, we did see a larger difference, at least by in terms of the number for the magnitude, than in the overall group. And this represented about 60% of the patients who were enrolled in the study. So I want to take my second detour and say, if I'm a treating physician or more importantly, a patient looking at this data, I might say to myself, well, that's great, but what does that mean to me? And so the experience I draw off of when I was treating my severe asthma patients was, these were patients who were going to the hospital probably at least once a month, who couldn't get across a room without being short of breath. And for them, a lot of the drugs that have been approved have been based on FEV1, which is the amount of air that you can blow out in 1 second. And countless times I remember them saying, I could care less how much air I can blow out in 1 second. I want to be able to get across a room. I want to be able to go shopping without having to sit down for 5 minutes. And so in that same vein, here we wanted to say, how do we know if this is clinically meaningful to patients? So what we did, I keep forgetting that does not advance it, but what we did was create a scale called the GNEM FAST scale, or Functional Activity Scale. So the way that you create these scales, which are patient-reported outcomes, is you ask a group of patients a whole laundry list of questions, trying to determine what is meaningful for patients. So what were you able to do 5 years ago that you can't do now? What can you do now that you wish you could do better? And ultimately have them select what is meaningful for them. Now, again, every patient is different. And so when you're looking at this list, some of these things might be meaningful to you, others not. But this is where we ended up with a scale looking at 3 domains. And these domains are broken down into what's called the mobility domain. And this is largely reflective of lower extremity or leg strength, the upper extremity, which is upper extremity or arm strength, and then self-care activities. And so the purpose of this, again, is to have patients develop a questionnaire that is meaningful to them for their disease. And what we saw, if you look again at the 48-week combined 6 group versus 3 group, you had improvement in the total score, the mobility score, and the upper extremity score. And we first looked at it by ANCOVA, but the general estimate was felt to be better because it was a repeated measure. Are there any statisticians in the audience? All right, well then you can trust me that it's no. I'm just kidding. I think the point here being is that we observed differences in a scale that was developed to show meaningful differences in patients. So we're encouraged by that we were seeing stabilization of muscle strength in the upper extremity and did look to see some improvements in a scale that was based on what patients had identified as being meaningful to them. Now, in the lower extremities, we saw maybe a slight improvement in the 6 group versus stabilization, but really no difference compared to the 3-gram combined group. And in part, I think that was due to the 3-gram group not having the same decline that we saw in the upper extremities. So we wondered about why that might be. And if you look at decline, patients will decline more rapidly potentially and then stabilize out. But you may get to an asymptotic portion of the curve. And so we look to say, well, what are these patients' strength compared to what an age-matched, gender-matched, unaffected individual might be? and their baseline strength was quite low at 25% of normal. So one of the thoughts might be is that rate of decline has gotten quite low and maybe slowing down. So that at least was a theory about why an effect was not observed and why this lower extremity strength did not decline. We looked also at serum sialic acid levels, and they rose just as we saw in the phase 1 study. And we did the 6-minute walk test, saw no significant change there. We did the sit-to-stand test and did see a trend towards improvement. So looking at the safety, it was generally safe and well tolerated. Most of the adverse events were related either to procedural pain from biopsies or due to GI side effects. We had no serious adverse events, so those are things that would mean the patient went to the hospital or had a very serious medical event that was life-threatening. We didn't see any of those. I didn't show the extension data in the interest of time. Again, I'm happy to discuss it with whomever. I have it on my laptop here. But we did have patients go from 6 grams up to 12 grams. And I would say from a safety perspective, we did see more GI side effects. We didn't see substantial improvements in efficacy if you look across the whole population. So in summary then, for our phase 2 study, we did see that the patients enrolled in this study appeared to demonstrate a stabilization of their muscle strength. They slowed the disease progression that we saw in the combination 3 group and in the placebo group. And this was based on upper extremity or arm and upper muscle strength. It was generally safe and well tolerated, and the phase 3 study planning is currently underway. So I will stop there and take any questions you might have, and I'll be here all day and at the patient day tomorrow. So would love to talk to you then as well.
Questions?
Yes.
So what's the hypothesis about the quadriceps?
Yeah, so the hypothesis is, and we have others in the room who can certainly weigh in, would be that that there's more sialic acid production in the quadriceps. So, you know, sialic acid is, or the GNE gene is highly conserved across all animal species. So the thought, or the reason that it's thought to affect the muscle tissue is because there's relatively less in the muscle tissue. What I've heard is that, at least in the quadriceps, there's thought to be more. So it doesn't quite reach that critical threshold. It's a defective enzyme, but there is still activity. There is still sialic acid there. So the thought being, again, in the quadriceps, you haven't hit that threshold level below which you would have non-functional proteins that would then lead to the replacement with fat and fibrosis.
How is that sialic acid important for
I
the
think that's the unanswered question, is that we know the sialic acid levels are low. There's been good research trying to look at sialylated proteins and correlate that with muscle function. That's not my field of expertise, but I am learning about that and hope to learn more about that today. So I don't have a good answer for you. Yes?
You mentioned at the end, once you got up to 12 grams dosage, you did start to see a few adverse effects. Now, were they beyond the gastroenterological?
No, sorry, I should have mentioned that. They were all they were all GI side effects, and most of them were increased flatulence, seen at the 12-gram compared to the 6-gram. Sure.
Based on what you know, is there any benefit from patients eating diets rich in foods that have lots of sialic acid in them?
Yeah, you know, I don't know. It's a great question. I don't know if any of you all want to comment or if any of the other researchers want. I don't know if there is data. There very well could have been studies done looking at that, but I'm not aware of them personally.
Well, goat's milk, it's said, to be high in sialic acid. So many of the patients
are drinking goat's milk. Interesting.
Mm-hmm.
Has it ever been looked at, do you know, to say?
Yeah, there were some studies done, really old studies that show it was high in sialic acid, but not with HIBM or anything like that. Yeah.
Okay.
Very
interesting.
I think one of the things to keep in mind is that in different cells, different tissues, we don't have an idea of how much sialic acid comes from the de novo pathway, which is what this is, or from the salvage or dietary input pathways. We don't know about those balances. So it's kind of hard to say. Then if you have sialic acid that is part of a component, sialolactose, things like this, that may get into cells and be trafficked and be utilized in a very different way than sialic acid itself. And the same thing with Mannac. So there are, again, it goes back to the basic science, a lot of the stuff that we don't know how these things will impact. And the hope is we're going to start expanding some of those perspectives. But at the moment, more questions than real answers and great data.
Thank you.
What?
Yeah, sorry, Karen.
Will phase 3 study design be the same as phase 2?
So we are making some differences with regards to the enrollment criteria. We're also going to be doing a non-ambulatory study. So one of the differences, and is that patients enrolled will have to be able to walk 200 meters or more. So it was more than 20 meters in the phase 2 study. We're also planning a non-ambulatory study. We haven't, defined, does that include patients who can walk less than 200 meters, or is it, we have yet to define those cutoffs. But what we really want to do is study the population broadly, because we recognize that, again, different patients have varying levels of muscle decline. Thank you.
Okay. Thanks, Ed.